Good morning, good afternoon, everyone. So this is a new horizon in the lung cancer treatment, that is analyzing the MRD, that is molecular residual analysis, that is from the ADAURA trial by Thomas John et al. It was an oral abstract which was presented in ASCO this year. So just refreshing the ADAURA phase 3 study design. So patients with completely resected stage 1B to 3A NSCLC with or without adjuvant chemotherapy with EGFR exon 19 deletion and L858R, they are randomized either to osimertinib 80 milligram OD for 3 years versus placebo. So the 5-year updated analysis is the DFS with the hazard ratio of 0.27, and the 5-year OS was 88 versus 78% with a hazard ratio of 0.49. So what they did in this study is the main endpoint was whether they evaluated the feasibility of the ctDNA based MRD detection, whether it is going to predict the disease recurrence either during adjuvant osimertinib treatment or in the post-treatment follow-up. So how they analyzed this? So they collected samples, that is the blood samples, plasma samples. The ctDNA samples were collected one at the baseline, that is either during post-surgery or plus or minus adjuvant chemotherapy, that is at baseline. Then during adjuvant treatment, that is for the 3 years, every 12 weeks it has been collected. Then from 3 years to 5 years, first week 12 and 24, and then every 24 weeks. Then after 5 years, every 52 weeks, the sample has been collected. So whether this tumor-informed MRD can be a biomarker for disease recurrence, because in early stage NSCLC and in adjuvant settings, detecting a ctDNA can be challenging because of the low tumor burden. And there are studies in early stage disease which support that the use of tumor-informed MRD assays can be done using a high-depth NGS. So when a MRD is detected in plasma, that means that you are detecting a clinically undetected cancer cells. So it can be used as a biomarker for early disease recurrence and could inform the treatment and prognosis. In this study, how they did using a RADAR-R platform, that is from the tumor sample, whole exome sequencing has been done, then from tumor-specific ctDNA panel design has been created, and then germline DNA panel validation has been done so that they are excluding the germline and chip variants, and they analyzed the plasma longitudinal MRD monitoring via the NGS. So some definitions for this is, one is the MRD undetected at baseline, that is during randomization. The second is MRD detected at baseline. So even if detected at baseline, during treatment, that is the MRD clearance, that is it is undetected within the first 2 time points. And the last one is MRD detected during study. How they are, the MRD detected means the plasma ctDNA, it becomes positive for 1 or more mutations in tumor-informed patients. And by analyzing this, they have assessed in relation with the DFS events. So MRD positive, it has been assessed in relation with the DFS events, that is the clinical recurrence or death in both arms. So in ADAURA trial, total 682 patients were randomized, but tumor plus DNA samples were analyzed in 242 patients. Out of this, 220 patients, the MRD analysis set was analyzed. 112 in the osimertinib and 108 in the placebo arm. So baseline characteristics, they were almost similar in both arms. So as we know that because osimertinib has been given, so MRD events were detected in 49% in the placebo group versus 13% in the osimertinib group. So by doing surgery followed by plus or minus adjuvant chemotherapy, at baseline, MRD was undetected in almost 92% of the patients, whereas 8% had MRD positivity. That is most common in the stage 2 and stage 3A patients. Those patients who had MRD detected at baseline, they were associated with poor outcomes. So total number of patients were 18. Out of 18 patients, 5 patients were in the osimertinib group. So here you can see the blue color is the osimertinib. But even though MRD detected at baseline, in the first 3 patients you can see they have MRD clearance has been done, and they have completed 3 years of adjuvant osimertinib. But after stopping the osimertinib, the disease has recurred. And the 4th and 5th patient, in the 4th patient, MRD cleared, but again it recurred, and the disease has recurred. But the 5th patient, there is no clearance. So out of 5 patients, 3 patients completed 3 years of adjuvant osimertinib, and after stopping, the disease again recurred. So a patient becoming MRD positivity, whether it is correlating with the DFS events, that is clinical recurrence or death, yes, it has a mean lead time of around 4.7 months. So after the completion of 3 years of adjuvant osimertinib, 86% of the patient in the osimertinib arm, they were DFS and MRD event free. overall, that is 3 years of adjuvant osimertinib and 2 years of post-treatment follow-up, 75% of the population in the osimertinib arm, they were MRD negative or DFS even free. And the rest 25%, in that 25, 8% they recurred during the treatment. And the rest 17% they recurred post-treatment. And that too, if we dissect that 17%, in the first 1 year post-completion, 58% recurred. So within 2 years post-treatment discontinuation, almost 95% of the patients recurred. So they have analyzed still further, that is post 3 years of adjuvant osimertinib, 2 years of follow-up. So 2 years post osimertinib discontinuation, 66% of the patient, they had MRD or DFS even free. That means there is a group of population who is going to recur post stopping of adjuvant osimertinib. So it has to be taken with a pinch of salt, whether, just like the LAURA trial, as Sarah's mentioned, post CTRT continuing the osimertinib till progression, or as per the ADAURA, we have to stop it, because still we don't have a data at present whether post surgery we have to continue more than 3 years or not. But this MRD, it will be in the future become a both prognostic and predictive marker, whether to continue the treatment or to stop where. So coming to the conclusion, so in ADAURA, we have 3 years of adjuvant osimertinib. It showed a statistically significant and clinically meaningful DFS and OS. And the tumor-informed MRD in ADAURA, it was feasible. It identified recurrence with a mean lead time of around 4.7 months in this study. So MRD analysis, it demonstrated the maintenance of both DFS and MRD even-free status for most patients during and also after osimertinib treatment, and it was able to identify the molecular recurrence prior to the DFS events. As mentioned, the mean lead time of around 4.7 months, it highlights the potential to monitor and personalize patient care in this setting. So this is the more way forward. Thank you.